This is Dr. Joshua Cooper, and I'm very excited to bring to you a series of modules on atrial flutter. We're going to talk about the diagnosis of atrial flutter and catheter ablation, focusing on the principles that I've presented in previous videos, including electrogram interpretation, activation mapping, and entrainment mapping. So let's get on with module number 1. We'll start with typical right atrial flutter, including a review of right atrial anatomy and the natural barriers to wavefront propagation, and we'll talk about how to position catheters in the right atrium in different scenarios so that you understand how to interpret electrogram sequence during flutter, during sinus rhythm, during pacing maneuvers, and of course also how to interpret activation maps and entrainment as well during atrial flutter. So let's start with the right atrium, which here is represented as a simple sphere. Blood enters and exits this chamber via structures that act as natural electrical barriers. There are 3 veins that bring blood into the right atrium, including the superior vena cava, the inferior vena cava, and the coronary sinus, which enters the inferior aspect of the interatrial septum. Blood exits the right atrium via the tricuspid valve. This is essentially a left anterior oblique or LAO view, and so the tricuspid valve is sitting toward us, and the right ventricle would be on our side of the screen as we're viewing the chamber from this direction. The crista terminalis is a muscle ridge that runs down the lateral aspect of the right atrium, and in most people, the muscle fibers that run along this ridge are oriented in the top to bottom direction, which means that electrical signals tend to travel much better and faster downward or upward along the crista terminalis along its length rather than transverse or across the crista terminalis. So this ridge structure acts essentially as a functional electrical barrier in most patients. The space between the inferior vena cava and the tricuspid valve is known as the cavo-tricuspid isthmus. And just to refresh your memory from grade school, an isthmus, geographically speaking, is a narrow strip of land that connects 2 larger land areas. But anatomically speaking, an isthmus is a narrow anatomic part that connects 2 larger structures or cavities. Let's take a moment and pretend that we're floating inside the right atrium and look downward at that cavo-tricuspid isthmus. Here we are staring downward, and let's see what that would look like. Here's what the cavo-tricuspid isthmus would look like if we stare at it looking downward from the middle of the right atrial chamber. Posteriorly, you have the inferior vena cava, which serves as one border, and anteriorly, you have the inferior portion of the tricuspid valve, or the tricuspid annulus. And you can therefore see that there's a narrow portion that connects the lateral aspect of the right atrium to the medial aspect of the right atrium and the interatrial septum. Therefore, this is an isthmus by definition. Now that we appreciate the right atrial anatomy and the natural barriers that occur in the right atrium, we can start talking about the various flutter circuits that are possible. The most common one is counterclockwise right atrial flutter, also known as typical flutter because it is the most common. There's a very characteristic path or circuit that's followed during typical flutter, and that includes a wavefront traveling up the interatrial septum, across the roof of the right atrium, down the lateral wall of the right atrium in front of the crista terminalis, and then across that cavo-tricuspid isthmus, that portion between the inferior vena cava and the tricuspid valve, which I'm going to show here in green. Another term that's used for typical flutter is isthmus-dependent flutter, because this wavefront necessarily must travel across that cavo-tricuspid isthmus in order for this particular circuit to perpetuate. Typical flutter has a typical appearance on the EKG, where in the inferior leads, 2, 3 in AVF, you have negative flutter waves with a very gradual downslope and a more rapid upstroke, here shown with the red arrows. The reason that there's a superior axis of the flutter waves is probably twofold. First, the wavefront travels in an upward direction on the interatrial septum. And second, the wavefront, when it travels from right atrium to left atrium, crosses that septum at the part of the where the coronary sinus connects the 2 chambers. And so the left atrium is also activated in a bottom to top direction. And because of that bottom to top direction, you have a wavefront that travels upward, creating those negative flutter waves in the inferior leads. In V1, you typically see the opposite orientation with positive flutter waves there, and this likely reflects the wavefront coming toward V1, toward the front of the chest, across the top of the right atrium. And here's a terrific 3D electroanatomic map showing the sequence of activation and wavefront propagation in both the right and the left atrium during counterclockwise right atrial flutter. And before we get into it, I want to first thank Dr. David Singh and several other people who have posted fantastic videos and images on Twitter to share with the EP community and beyond. I really appreciate their, first of all, posting these wonderful images, and second of all, allowing me to share them in this presentation. So here we're going to start this movie in motion, showing wavefront propagation traveling across the cavotricuspid isthmus, up the interatrial septum, which I'm showing with a yellow arrow, as well as that connection near the coronary sinus, showing an inferior to superior wavefront propagation in the left atrium as well. Let's watch that a second time and note the wavefront traveling in an upward direction during counterclockwise right atrial flutter, and that explains the negative flutter waves in the inferior leads. Now, if we look at the reverse circuit, which is the same in its route but the opposite in direction, this is clockwise right atrial flutter, where the wavefront will travel, in this case, down the interatrial septum, across the cavotricuspid isthmus in the opposite direction, up the lateral wall of the right atrium, again in front of the crista terminalis, and then back over the roof toward the top of the interatrial septum once again. This also travels through the cavotricuspid isthmus, and so it's also essentially referred to as isthmus-dependent flutter, because again, the wavefront necessarily must travel through that isthmus between the IVC and the tricuspid valve. Here on the 12-lead EKG, you're going to see flutter waves of opposite direction, positive in the inferior leads 2, 3, and AVF, because the wavefront in this case is traveling downward on the interatrial septum, and when there's a clockwise circuit in the right atrium, now the communication between right and left atrium occurs over Bachmann's bundle, the top of the chambers, and the wavefront travels in a downward direction in the left atrium as well, giving you those positive flutter waves in leads 2, 3, and AVF. And again, the opposite is seen in V1, where these flutter waves during clockwise right atrial flutter are negative, reflecting a front to back component of the flutter circuit and activation of the atria. Here again is another terrific video from Dr. Singh showing clockwise right atrial flutter, emphasizing the sequence of activation on the septum, and in the left atrium showing a top to bottom direction. Here we're going to see a wavefront travel across the top of the right atrium, down the interatrial septum, downward in the left atrium as well, and then of course across the cavotricuspid isthmus on the floor of the right atrium. Let's watch that one more time, again explaining why the flutter waves in clockwise right atrial flutter are positive in the inferior leads. Let's now talk about how we place catheters in the heart for an atrial flutter ablation procedure. The purpose of putting catheters in the heart is to record wavefront propagation, and therefore we sample the electrograms at various places around the right atrium and in the coronary sinus. So typically people will use a multi-electrode catheter that's looped around the right atrium, often in this configuration, having 10 or 20 poles, meaning 5 or 10 bipoles in pairs. And the purpose of placing this at this location is to be able to record electrograms down the lateral wall of the right atrium, across the isthmus, and into the coronary sinus. And I reviewed in my electrogram lecture how these electrodes are numbered. We can either number them as pairs, like here, where we have electrode pair 1, electrode pair 2, all the way up to electrode pair 10. And by the way, this catheter having 20 poles is called a duodeca catheter, so these may be labeled on the screen when we're looking at the electrograms as D1 through D10. Sometimes instead of numbering pairs of electrodes, you'll see people label all the electrodes individually. And on the screen of the electrograms, you'll see labels such as duodeca 1, 2, duodeca 3, 4, and onward. And that's just individual preference, how it's displayed on the screen, but I just wanted to review those so that when you see various people showing electrograms during atrial flutter, you'll understand their numbering scheme. Here we see the duodeca catheter with pairs of electrodes numbered, and now I've highlighted that cavo-tricuspid isthmus again in green, showing that we do have electrodes on the isthmus and on either side of it. Here is that counterclockwise right atrial flutter pathway, showing that the wavefront travels around the chamber as we reviewed before, and then of course also extending out the coronary sinus from a right to left direction. Here's an actual duodecapolar catheter sitting in the right atrium with the tip extending into the coronary sinus in a patient with typical atrial flutter. We again number the electrodes from the tip of the catheter backwards. And on this LAO fluoroscopy view, let me superimpose the anatomic structures so that you can appreciate exactly how this catheter sits. The catheter is looped around the right atrium with electrodes traveling down the lateral wall, across the isthmus, and into the coronary sinus. And the tricuspid valve is facing out at us in this LAO view. Here is the wavefront propagation sequence, traveling around the right atrium in a counterclockwise direction, and of course traveling out the coronary sinus in a right to left direction, anatomically speaking. Pay attention to the sequence that the electrodes are being activated during this flutter circuit, and we're going to review that in the next module. Here I've removed the anatomic structures to again highlight the path of the circuit and looking at the sequence of electrodes as this wavefront travels counterclockwise around the right atrium. One last point about catheter positioning is that it's very important in the RAO view to ensure that your catheter is sitting in front of the crista terminalis. Here I've drawn in the crista terminalis and showing the catheter in an incorrect position with the body of the catheter sitting posterior to the crista. The reason why this is a problem is that the wavefront travels anterior to the crista in typical flutter, and if you're going to be doing entrainment maneuvers or interpreting activation sequence, you can sometimes be misled about the nature of flutter if your electrodes are positioned behind this electrical barrier rather than in front where the circuit's actually traveling. Here in this patient, we torqued the catheter a little bit in order to bring the catheter now in front of the crista terminalis, and that's going to be much more useful as you interpret electrograms and entrainment maneuvers, which we'll review in a little bit, because again, the wavefront is going to be traveling along the catheter now between the tricuspid annulus and the crista terminalis. Okay, here's where it starts to get more exciting. We're going to use our multipolar catheter in the right atrium and coronary sinus to evaluate the electrogram activation sequence in 3 different examples of atrial flutter. So we could also call this segment a tale of 3 flutters. Here's flutter number 1 in a patient with prior coronary artery bypass surgery. Here's the 12-lead EKG, and let me zoom in on leads 2 and V1, because we reviewed before that if you see negative flutter waves in the inferior leads and positive flutter waves in V1, that is characteristic of counterclockwise right atrial flutter. And here you can also see the gradual downslope in the inferior leads, in lead 2 in this case, and the more rapid upstroke, very characteristic shape of typical counterclockwise right atrial flutter. And here are the electrograms in that first patient with a duodeca catheter looped around the right atrium with the tip in the coronary sinus, as I reviewed before. And now let's review the sequence of activation in the electrograms from which we're recording. You can see that the sequence of activation is duodeca 10 and then 9, 8, all the way down to 1, which anatomically speaking is a counterclockwise route around the right atrium and traveling out the coronary sinus, consistent with counterclockwise right atrial flutter. Here's just another catheter configuration that some people prefer for atrial flutter cases. Instead of using one catheter that loops around the right atrium and travels with the tip in the coronary sinus, people may use two separate catheters, one looping around the right atrium and the second in the coronary sinus. The one in the right atrium is often a 20-pole catheter, known as a halo catheter frequently, and then the one in the coronary sinus typically has 10 electrodes, and again it's advanced all the way into the coronary sinus with electrode pair 9-10 usually sitting at or near the interatrial septum. And so if you have counterclockwise typical flutter, you'll see that the wavefront propagation will travel around the right atrium, and you'll see the separate wavefront traveling out from right to left in the left atrium and in the coronary sinus. There's the cavotricuspid isthmus in green on the floor of the right atrium again. And notice in this scenario, you don't have any electrodes present on the floor of the right atrium. Some people just don't want to have a catheter there because they feel it may interfere with ablation catheter positioning and manipulation. But the downside is you can't record from your multipolar catheter anywhere near the isthmus, which you'll see in a little bit is the location where we'll perform ablation for typical flutter. Here's what the electrograms will look like when you have two catheters in the right atrium and the coronary sinus. In typical flutter, counterclockwise direction, you'll have the yellow arrow here, one wavefront traveling from 1920 all the way around to 1-2, and you can see that here in the electrograms. And then, of course, as the wavefront travels out the coronary sinus, you'll have a vector traveling from CS 910 out toward 1-2. But again, because we don't have any electrodes on the floor of the right atrium, you're going to see here a gap in time before the wavefront passes from electrode 1-2 in the halo catheter until it travels to 9-10 in the coronary sinus catheter. And that's reflected here in the absence of any signals between this part of the wavefront and this part of the wavefront. Let's move on to patient number 2, a patient who had prior mitral valve surgery. And if we zoom in on the inferior leads and in lead V1, you're going to see that this patient also has negative flutter waves in the inferior leads. Here I've shown lead AVF, and positive flutter waves in lead V1, again consistent with the possibility of counterclockwise right atrial flutter. In this case, however, we see electrograms that show a different story. This case involved two catheters, the halo catheter in the right atrium and the coronary sinus catheter in the coronary sinus. And again, to review and anatomically speaking where they're sitting, there's the dotted line showing the interatrial septum and the right atrium and the left atrium in this LAO view. And let's break this down and look at some electrodes at a time in small bits, because the picture overall, when you first look at it, can sometimes be confusing. Let's focus first on the coronary sinus catheter, which I've now enclosed in a brown rectangle. And you can see here the wavefront travels from electrode pair 9-10 to 7-8 and out to 1-2. And fluoroscopically speaking, that translates into a right to left direction, again consistent with the possibility of right atrial flutter. Now let's move on to the halo catheter, which is a little more complicated in this case. And let's break that down into two parts. First, if we look at halo 5 to halo 1, we can see the direction that that wavefront is moving. And I'll draw the green arrow corresponding to that wavefront direction, again consistent with counterclockwise right atrial flutter. But if we look at halo 6 through halo 10, we're going to see here the wavefront travels in the opposite direction, not what we saw in the previous case. And let's draw that arrow in here as well. And this shows a clockwise propagation wavefront here. And so this isn't as simple as a circuit traveling only in one direction or the other, because we have wavefronts traveling in two different directions in this case. We're going to review in the next module how we can further flesh out what's going on using entrainment maneuvers, but just looking at the sequence of activation in the halo catheter, we're now going to wonder if there's maybe either a focal tachycardia starting somewhere here on the lateral right atrial wall, or even a small circuit that involves the lateral part of the right atrium as well, sending wavefronts in two different directions. Let's turn our attention to flutter number 3 and patient number 3. This patient had a previous typical right atrial flutter ablation, but they come back with atrial flutter, and this is the bane of our existence when we think that we're seeing a recurrent arrhythmia that we thought we got rid of with a previous procedure. Here in lead 2, we see negative flutter waves, characteristic of counterclockwise right atrial flutter, and positive flutter waves in V1. And so we're worried about a recurrence of a flutter that was previously ablated. Here is a duodeca catheter wrapped around the lateral part of the right atrium and extending into the coronary sinus, and let's evaluate these electrograms, again in segments. First, if we look at duodeca 10 through 6, we can see that that wavefront direction is consistent with a counterclockwise right atrial flutter. If we look at duodeca 3 through 1, again, we can see travel from right to left in the coronary sinus, again consistent with counterclockwise right atrial flutter. However, if we look at duodeca 3 through 5, you see the opposite direction of wavefront, traveling in a clockwise direction across the medial floor of the right atrium, not consistent with counterclockwise right atrial flutter. And we're going to also review this case in the next module where we talk about entrainment to further flesh out what's going on. So as promised, here we're going to now review entrainment maneuvers in those 3 flutter cases, all of whom had negative flutter waves in the inferior leads and positive flutter waves in lead V1. You'll get the most out of this module if you review my video on entrainment, where I go in more detail about how entrainment is performed and how to interpret the post-pacing interval. So let's move on and look at entrainment maneuvers in these 3 cases to further characterize the 3 different flutter circuits. So here's the first patient with what we suspected was typical flutter. And now, in addition to having the duodecapolar catheter positioned in the right atrium and coronary sinus, we have an ablation catheter that is positioned right here on the cavotricuspid isthmus. And we're actually going to cut to the chase with this entrainment maneuver by pacing from that ablation catheter right on the cavotricuspid isthmus, here shown in green. The cycle length of the tachycardia is 260 milliseconds. And we paced here a little bit faster than that at 240 milliseconds from the ablation catheter. We, of course, confirm that we accelerated the tachycardia to our pacing rate, and then we interpret the post-pacing interval in that same electrode from which we paced. And here the post-pacing interval was the same as the tachycardia cycle length, showing us that this location is in the circuit. And since it's on the cavotricuspid isthmus, we were able to proceed directly with ablation across the isthmus to treat this tachycardia. Entrainment maneuvers were also performed, which I will not show in this case, at other electrodes around the right atrium, showing the post-pacing interval equal to the tachycardia cycle length at different locations. And I actually review that example in my module on entrainment. And sure enough, as we predicted from entrainment on the cavotricuspid isthmus, ablation across that critical portion of the circuit resulted in flutter termination. And here is that patient number 2 who had previous mitral valve surgery with wavefronts that were not consistent with typical counterclockwise or clockwise right atrial flutter, because in green and in purple we had wavefront propagation that traveled in opposite directions around the right atrium. Well, let's think about entrainment to further characterize whether this could have been isthmus-dependent flutter or not. Here is the cavotricuspid isthmus, again displayed in green, and we're going to perform entrainment maneuvers from halo 1, which is sitting very close, just lateral to the cavotricuspid isthmus anatomically. The tachycardia cycle length here is 230 milliseconds. And we pace here from halo 1. Normally you'd want to pace 20 or 30 milliseconds faster than the tachycardia, but the operator in this case paced a little bit faster, which increases the possibility that you might terminate the flutter, but in this case it did not. It stayed the same post-pacing as it was pre-pacing in terms of cycle length and activation sequence. So this entrainment maneuver was valid in that regard. We certainly were showing that the tachycardia accelerated to the pacing rate, showing that we indeed did capture the chamber. And now we can interpret the post-pacing interval in that same electrode pair from which pacing was performed. And now in this case, it's significantly longer than the tachycardia cycle length, suggesting that this lateral part of the isthmus is not in the circuit, and in fact not very close, because the distance between the two is 75 milliseconds. So here the flutter circuit is clearly not involving this part of the right atrium. And again, thinking back to wavefront propagation, we had suspected that maybe there was a flutter circuit somewhere on the lateral right atrium. And in fact, this patient had an incision, whether it was a cannula site or a surgical incision in this patient who had valve surgery. There is a flutter circuit here, very small, and therefore we're far away from it as we pace over here, electrically speaking, and the wavefronts were traveling out in both directions around the right atrium from that circuit. One clue from this slide that we have is that there's a lot of fractionation here in halo 6, right here on the lateral part of the right atrium. And as you recall from the electrogram module, fractionation suggests wavefronts traveling in different directions in a small area, suggesting myocardial fibrosis and scar, which was the case here. And in fact, ablation in this area of lateral scar terminated this small local atypical flutter circuit. Let's move on to that third flutter case where we saw again wavefronts traveling in directions that were not consistent with simple counterclockwise right atrial flutter. Here, if we perform entrainment from duodecapolar catheter 1 over here in the coronary sinus sitting in the floor of the left atrium, the tachycardia is 240 milliseconds, and we paced here at 210 milliseconds from duo 1. We show that we accelerated the tachycardia to the pacing rate, and we now can evaluate the post-pacing interval in that same pair of electrodes. And here, that pair of electrodes was in the circuit because the post-pacing interval was identical to the tachycardia cycle length. Now remember, we're here on the floor of the left atrium, far from the right atrium, and that suggests that maybe we're dealing with a left atrial flutter circuit, or at least that this electrode pair is in the circuit. Well, let's start moving toward the right atrium and do the same thing from electrode pair number 2, pacing at 210 milliseconds, verifying that we accelerated the atrial rate to the pacing cycle length, and evaluating this post-pacing interval. It again showed that that pair was also in the circuit because the PPI was the same as the TCL, post-pacing interval the same as the tachycardia cycle length. Now we add an ablation catheter that's positioned here on the floor of the right atrium on the medial side of the cavotricuspid isthmus. And we entrain from this location and see what we see. We, of course, confirm after pacing at 210 milliseconds that we've accelerated the atrial rate to that same cycle length. And if we look at the post-pacing interval after we come off pacing, we can see we're a little bit out of the circuit at this location. You can see the post-pacing interval is 270 milliseconds, which is longer than the tachycardia cycle length, although only by 30 milliseconds. So now we can conclude that from this location we were in, from this location we were in the circuit. Over here we're a little bit out of the circuit, although not far. And let's think about maybe pacing and entraining from one more location to flesh out what's going on. And here we're going to pace from electrode pair number 10. The tachycardia remains the same. We pace at 210 milliseconds. We confirm that we've accelerated the atrium to our pacing rate. But now we have a very long post-pacing interval after coming off pacing from duodeca 10. And that shows that this site is very far out from the circuit. So how are we going to put all of this information together to figure out where the flutter circuit is located? We can come to conclusions about what's going on when we combine our entrainment information with the sequence of activation information that we reviewed before. The actual flutter circuit here, we conclude, is traveling in a counterclockwise direction around the mitral valve, or at least around the left atrium, as you can see shown here in these bold yellow arrows, going upward along the lateral portion of the left atrium, across the left atrial roof, and down the interatrial septum. And that explains why we have wavefront traveling right to left in these electrodes, where electrode 3 is essentially positioned near the septum, but traveling in the opposite direction across the floor as you go into the right atrium from the septum. And it also explains why we're traveling across the roof and down the lateral wall of the right atrium. And recall, in this third patient, we had done a previous right atrial flutter ablation, which actually was intact and held despite our initial concern. And that explains why, anatomically speaking, these electrodes out here are actually very far out of the left atrial flutter circuit, because wavefronts cannot travel to or from this part of the right atrium, because there's a line of block that was created from a previous right atrial flutter ablation at the cavo-tricuspid isthmus. I showed that electrode pair 10 was way out of the circuit. In fact, entrainment from electrode 7 and 6 was even further out of the circuit, because while we're getting anatomically closer to the circuit, electrically speaking, this is very far away, because this is a line of block, and the only way to get to and from the circuit is over across the roof and up or down the lateral wall of the right atrium. So now we can see with entrainment and activation sequence where this flutter circuit is, and then design a strategy for catheter ablation. Because I enjoy entrainment so much in atrial flutter cases, I'm going to give you a bonus case to demonstrate the power of entrainment in figuring out flutter circuits. Here's another case where we use only electrogram sequence and entrainment maneuvers to show what's going on in a complex flutter ablation, showing that it can supplement, if not fully substitute, for 3D mapping in cases such as this. Here's a patient who has a history of sleep apnea who presented with atrial flutter with no previous ablations or surgeries. And we can see here in the inferior leads, there's sort of positive flutter waves and maybe negative flutter waves in lead V1, perhaps combined, suggesting that this is a clockwise right atrial flutter, but we won't know until we put catheters in the heart. So here we put a catheter in the heart, a duodecapolar catheter around the right atrium and into the coronary sinus. And the first thing we look at in flutter is the activation sequence. There it is, top to bottom, left to right. But you have to be careful, and this is true of every single slide where you see intracardiac electrograms. You need to read the labels, because if you didn't read the labels, you might conclude that this is counterclockwise flutter. But the operator here decided to label duodeca 1 at the top and 10 at the bottom instead of the other way around, which is what I was showing in previous slides. So here the wavefront travels from 1 to 2 to 3 all the way to 10, consistent with clockwise flutter potentially, or at least that's the wavefront propagation in those electrodes, even though it is also top to bottom and left to right, like the counterclockwise flutter appeared before, again because of the way that the labels are oriented on the screen. So let's move on to some entrainment maneuvers to verify that in fact we're dealing with isthmus-dependent clockwise right atrial flutter. We're going to start by entraining from the duodeca 4 pair, which is located right on the isthmus. And I'm not going to show each time here that we've accelerated the atrium to the pacing rate, which will be true in each of the slides I'm showing. And here the post-pacing interval is the same as the tachycardia cycle length, verifying that electrode pair 4 is in the circuit. So this is isthmus-dependent flutter. And here we're going to pace from electrode pair 9 just to verify that we're dealing with macro reentry around the right atrium. Here we see the post-pacing interval in red is 260 milliseconds, and the tachycardia cycle length remains the same at 240 milliseconds. And here we're only 20 milliseconds longer, not exactly in, but very, very close. And it may be that electrode pair 9 is sitting right on or maybe just posterior to the crista at this point, reflecting that it may be slightly out, but very close to the circuit. So now we know that electrode pair 4 is definitely in, and this is only very, very slightly out, confirming that this is a macro reentrant circuit traveling around the right atrium. And it's clockwise in direction, as we saw from the surface EKG and as we see from the activation sequence in the electrodes from which we're recording. So we start ablating across the cavo-tricuspid isthmus near electrode pair 4, and we can see while we're ablating that we're getting double potentials forming in our ablation catheter. I'm going to review this in a subsequent module in great detail. And as we continue to ablate, we can see that there was a cycle length change during ablation. We were at 240 milliseconds, and as we ablated, we now notice that we're at 280 milliseconds, so clearly we're having an impact on the tachycardia. And so, of course, we ablate a heck of a lot more on the isthmus, thinking we just hadn't yet achieved block. And here we are creating a whole cluster, not just a line, but a whole region of ablation across the isthmus. And the reason for so many lesions is it's just not terminating anymore. When you get into that situation where you think you've characterized the circuit and you've ablated, and especially if there's been a cycle length change, you need to reevaluate rather than keep ablating and ensure that you're still dealing with the same flutter. It's possible for atrial flutter to switch from one circuit to another, either spontaneously or in response to ablation. So here we're going to entrain from electrode pair 7. And now, in contrast to what we saw before, that the lateral right atrium was in the circuit, the post-pacing interval from this location is 360 milliseconds, which is significantly longer than the current tachycardia cycle length of 275 milliseconds, showing that we're no longer in or even near the circuit. So what do? We entrain from other locations. And what we did in this case, not pictured in this fluoroscopic image, but we advanced the ablation catheter out the coronary sinus to entrain from over here in the distal coronary sinus, just to see perhaps this had switched to a left atrial flutter, and we wanted to see if we needed to go transeptal and ablate in the left atrium. So that was the next step that we took, was to entrain from here. And we can see from this location, the post-pacing interval in red was 330 milliseconds, as opposed to 270 milliseconds of the tachycardia. So that's not in the circuit either. We then brought the ablation catheter back toward the proximal part of the coronary sinus, perhaps around this location, and now we showed pacing and entraining from this location resulted in a post-pacing interval that was much closer to the tachycardia cycle length, 290 milliseconds, although still very slightly out. So then we brought the ablation catheter right to the ostium of the coronary sinus, right at the interatrial septum, and trained from there. And you can see here the post-pacing interval was exactly the same as the tachycardia cycle length. And by the way, there's a little bit of fractionation seen on the ablation electrodes as well. But we can see that we're right in the circuit at this location on the inferior part of the septum at the coronary sinus. So then we said, okay, well, let's move up the septum a little bit and figure out what's going on there. And at this location, we entrained, and we're very slightly, only 10 milliseconds longer, essentially right in the circuit as well, just above the coronary sinus ostium. So we continued moving up the septum with the ablation catheter. Now we entrained from the high septum and showed that we're getting further away from the circuit at this location as well, with a post-pacing interval of 315 milliseconds as opposed to 270 millisecond tachycardia cycle length. So let's summarize the various locations where we entrained and figure out where the circuit must be. Here our post-pacing interval was the same as the tachycardia cycle length. So if you do a subtraction, the difference is 0. Here we're plus 10, so close, very close to the circuit just above the coronary sinus, going into the coronary sinus a little further away, and in every direction, up with the septum, out the lateral part of the right atrium, out the coronary sinus, we're getting further away from the circuit in each direction. And so that tells us that the circuit must be pretty small and located around the coronary sinus. Now there is a circuit that can happen that revolves around the coronary sinus ostium. It's actually not that uncommon to see typical flutter, either clockwise or counterclockwise right atrial flutter, convert to this coronary sinus ostial flutter after you've ablated across the isthmus. And that exactly was what was going on in this case. So we placed the ablation catheter right at the floor of the coronary sinus, between the coronary sinus and the inferior vena cava, this septal isthmus. And we ablated right there, and the tachycardia terminated. And so I wanted to make the point here that we didn't make at any point a 3D map of either the initial flutter or the subsequent flutter, and we sorted out two different flutter circuits purely by performing entrainment maneuvers and looking at activation sequence in the electrodes from which we're recording, and able to successfully ablate both flutters with those maneuvers in that interpretation. Let's talk a little bit about 3D activation mapping and the window of interest when it comes to macro-reentrant atrial flutters. For those of you who have seen my activation mapping lecture, you'll recall this slide where I compared a focal atrial tachycardia color pattern to that of a macro-reentrant flutter. On the left, you have focal tachycardia, where the earliest site in red radiates outward in all directions, showing that it has a focal nature. And at no point do you have the red early spot being adjacent to purple, the latest spot, which instead is on the far side of the chambers. On the right here, you have counterclockwise right atrial flutter, where instead of a radiating pattern in all directions, you have a circuit where red progresses through orange, yellow, and onward to purple, which then goes back to red. And in this scenario, you do have the earliest location in red adjacent to the latest location in purple, and that boundary is known as an early meets late line. And it is always seen when you have a macro-reentrant circuit. There's always atrial tissue being activated at all times during the cycle in that chamber, and therefore when you're making a map, you're going to reach the beginning after you revolve around the chamber or around the circuit once, and you're going to start the color pattern over again. Here's what these look like on the left with a 3D map of a focal atrial tachycardia in the left atrium coming from 12 o'clock on the mitral annulus, again with the red color signifying the earliest spot, radiating outward in all directions. And on the right, you have typical right atrial flutter revolving around the tricuspid annulus, showing the progression of red through purple, and in this case, an early meets late line down at 6 o'clock, which happens to coincide with the place that is ablated in order to terminate and prevent typical flutter or isthmus-dependent flutter from recurring. The data can be displayed in a variety of ways. Here is a different patient with counterclockwise right atrial flutter, again showing the color pattern from red through purple revolving around the tricuspid annulus in a counterclockwise fashion. Mapping systems often have the ability to show a video in motion instead of the static color image here, and that video will look something like this, where you can see an activation wavefront migrating around the chamber in the color sequence. And some people find that that video displays the arrhythmia in a more visually appealing way than just seeing the static color image. Here's a more advanced mapping display showing the local activation sites and the direction of electrical propagation locally, shown in the little white lines with tails on them, and then superimposed on that a graphic representation of a wavefront traveling in a counterclockwise fashion around the right atrium. Just another way of displaying the data, which really are acquired in exactly the same way, where you have a reference point and a color spectrum denoting early and late times in the chamber. And here's yet one additional mapping system showing how it displays counterclockwise right atrial flutter. Here we see the early meets late brown line revolving around the tricuspid annulus, and in fact all of the colors are revolving around the chamber in what I've called a disco pattern of activation wavefront propagation. Again, really appreciate Dr. Singh allowing me to share his terrifically detailed activation maps with you in this video. This is a really important activation map to appreciate, and thank you to Jerry Chun for allowing me to share this. If you look at the color propagation around this right atrial chamber, you're going to see red progressing to orange and through the color sequence back to purple, and it looks exactly like counterclockwise right atrial flutter, and you're going to ask why I'm even showing you this. But the answer is that this is not counterclockwise right atrial flutter. Even when I show the wavefront propagation in motion, it looks like typical flutter. But it turns out that this rhythm was a focal atrial tachycardia from near the coronary sinus ostium, from this location. And it turns out that the wavefront was propagating around in this direction and not radiating out in all directions, because either there was slow conduction across the floor, the isthmus, ablation had not been performed there previously, or there may have been a functional block in this area as the wavefront propagated around the first time, and then the second beat maybe met refractory tissue because of the amount of time it took to travel around the tricuspid valve, and that set up a perpetuating functional block along the isthmus. And in fact, ablation focally near the coronary sinus is what was successful to terminate this particular rhythm. I reviewed this concept in my activation mapping talk, where I showed two examples of mapping exactly the same focal tachycardia on the eustachian ridge on the medial floor of the right atrium. And here on the left, you'll see the wavefront propagation travels in all directions away from that focal origin, which is what you'd expect. But on the right, the example I showed was somebody who did previously have a cavo-tricuspid isthmus ablation line created, and therefore creating a line of block. So on the right, that very same tachycardia will have a very different activation sequence in the chamber. You'll see red will not propagate across the isthmus to orange because of that line of block, but instead you'll get unidirectional wavefront propagation in a counterclockwise fashion all the way around the tricuspid valve because of that line of block on the floor. And so on this right image, it looks like you have typical flutter, and it shows a pitfall of using only an activation map to determine the nature of a rhythm and therefore an ablation strategy. The way you would distinguish on the right typical flutter from focal tachycardia is you could do entrainment from over here, the lateral isthmus or the lateral wall of the right atrium. And if it were flutter, this would be in, your post-pacing interval would be the same as the tachycardia cycle length. But in this case, where you have a focal tachycardia and a line of block, this is very far from the origin of the tachycardia, whether it's focal reentry or a focal tachycardia. This will have a very long post-pacing interval, and that would be the way to identify that this activation wavefront is misleading, and this is not macro-reentrant atrial flutter around the entire chamber. I also reviewed in that lecture what would happen if you had the same counterclockwise right atrial flutter, but you used a different reference point. I showed earlier what that would look like with a coronary sinus reference point, and here is what it would look like if you had a different reference along the crista terminalis. You have a different time zero, and therefore each point around the right atrial chamber will have a different timing with regard to that reference. It still shows an early meets late line because this is counterclockwise macro-reentrant right atrial flutter that's dependent on the isthmus, but the location of the red and other colors will change depending on where the reference is situated. And here's a comparison of using a coronary sinus reference and using a crista terminalis reference of exactly the same rhythm, where you have the early meets late here at the 9 o'clock location along the tricuspid annulus, and on the right you have the early meets late down here at the 5 o'clock location, and yet it's the same rhythm. So the question arises, why does your color spectrum shift like this based on the location of your reference? And the answer is it depends solely on how you created your window of interest. And let's review that, because you can use a different reference, but in fact have the color scheme stay exactly the same. So let's review in detail the two main ways that people will create a window of interest when making a 3D activation map. We're first going to talk about creation of a symmetrical window of interest around a selected reference electrogram and what implications that has for how the colors show up in the map and how that will change when you select a different reference point. So here we have atrial flutter that you can see on the surface EKG. And here we have the coronary sinus catheter that we're going to initially use as a reference. And let's select coronary sinus 5-6 as our stable electrogram reference point, our time 0. And let's look at one very specific spot in the right atrium and see how that compares with our reference in our window of interest. So here we're going to pick a symmetrical window of interest around that reference point, factoring in the cycle length of the tachycardia and splitting that in half. So half of the window is earlier than the reference and half of the window is later. And here's that one point in the right atrium that we're going to look at and figure out how this will show up in the color scheme with this particular reference point and this window. So we'll find the local activation time, the sharpest electrogram of that bipolar recording, and it happens to show up earlier than our reference, and it's in the first part of our window of interest. And so when we end up mapping the entire chamber, and colors will be assigned accordingly based on early versus late in our window, this location will come out as a yellow color in this window. What if we did the same thing, meaning creating a symmetrical window, but using a different reference point and looking at this identical point in the right atrial chamber as we do so? Same atrial flutter rhythm, but now we have a crista terminalis catheter with the tip, let's say, up in the superior vena cava. And let's select crista 3-4 as our reference. And let's see what happens as we create a window of interest that is symmetrical around this new and different stable reference point. There's our window of interest. And notice now that our local activation time at this identical point in the right atrium is now going to fall later than our reference and later in the window of interest. And so now this same point in 3D space is going to be colored sort of in the blue to purple range as we finish mapping the entire chamber and look at this spot in particular. So now you can see by creating a symmetrical window around a reference point that the reference point is going to dictate where the window lies, and therefore every point that we map is going to fall in a different part of the window because the window has shifted. Let's look at a different strategy for creating a window of interest, and it's known as the DePonte window, based on a manuscript by DePonte et al. That talks about creation of a window of interest, not based on the electrogram that's chosen as a reference, but instead based on the surface EKG. The way this window is created, the left caliper of the window is placed in mid-diastole, and the right caliper is extended out to most of the cycle length of the tachycardia, 95%. Some people use up to 100%, some people use 90%, but the point is the width of the window occupies most, if not all, of the cycle length, but the left caliper is positioned very specifically at mid-electrical diastole. So let's see what happens as we select the same two reference points and look at that same point in 3D space that we were mapping and what the implications are on the color scheme. So here again is our CS56 reference. And notice now it does not, of course, fall in the center of the window. It's a little bit asymmetric, a little bit shifted to the right, because the window is not dependent on that electrogram. It's dependent on the surface flutter wave. And so how will our single point in 3D space fall in this window? Well, it's going to map to the green color because it falls a little bit before the halfway point in our window of interest, and it happens to fall as before in front of our reference electrogram. What if we did the same thing, meaning make a DePonte window, but use a different reference? So here is our same DePonte window that again does not rely on the reference, but relies on the surface flutter wave. And now look, our Krista 3-4 reference point that we used before falls again in a very different place in the window. It's very asymmetrically positioned, and that's fine. As long as you have a stable time 0, you're going to have, in this case, fewer negative points and more positive points, but that's okay. And you're going to create a color scheme that is based on the window of interest rather than the electrogram itself. And let's look for the last time at that exact same point in 3D space. Notice that it falls later than our reference, but at exactly the same place in our DePonte window. So it still gets colored green as it was before, even though we chose a different reference. So the main advantage of a DePonte window is it's going to give you a very predictable color scheme irrespective of what you choose as your reference electrogram. And moreover, if you have an area of slow conduction in the chamber for this macro reentrant circuit, then that's going to end up usually being colored red, because that slow conduction is going to make the smallest deflection on the surface EKG. It's going to fall between the flutter waves at the lowest amplitude point, and that will be colored early. And so that's more likely to coincide with an area that you may end up ablating if in fact you end up ablating at an area of slow conduction, especially with atypical flutter circuits. So sometimes people like that advantage of knowing where the slow conduction area is, although for many circuits you rely really more on anatomy. You want to make the shortest line that'll interrupt the circuit and the safest line that is least likely to cause collateral damage. But anyway, those are the two ways to set up a window of interest and the implications on your 3D map. Let's move on to talk about where and how you create a line of block for macro reentrant atrial flutter. Here's my cartoon of the right and the left atrium, and let's discuss the most common types of flutter and where we might make ablation lines to terminate them and prevent their recurrence. The most common flutter, of course, is typical flutter, counterclockwise around the right atrium or clockwise across the isthmus. And because we have very convenient electrical barriers that we can connect one to the other at a relatively short distance, that being the inferior vena cava and the tricuspid annulus, this cavo-tricuspid isthmus line, or CTI line, is almost always the line of block that is created in order to treat typical counterclockwise or clockwise right atrial flutter. In patients who have a scar on the lateral wall of the right atrium, often from previous cardiac surgery at a cannulation site or an incision site where valve surgery was performed, we need to connect this scar to another barrier. And often that is the superior or the inferior vena cava, depending on where the scar is located. So you'll make an ablation line between that scar and the SVC, for example, but you have to remember a couple things anatomically. Number one, very commonly you'll see myocytes extending a little ways up into the SVC, so either you're going to need to make burns up into the SVC to connect to electrically inactive vein tissue, or you need to create a little line of burns around to isolate the SVC, and that'll serve as the other anchor on this end of the line between the scar and the SVC. You need to either way remember that the sinus node sits in this location, as does the phrenic nerve to the right hemidiaphragm. So when ablating in this area, you have to remember those structures and be cautious not to injure them. Mitral flutter is another very common flutter, either clockwise or counterclockwise in the left atrium around the mitral annulus. Now here we don't have the equivalent of an inferior vena cava to anchor one end of the line. And usually these patients will have had or are at risk for having atrial fibrillation. And even if they haven't had it, it's very helpful, probably both to eliminate triggers, but also to create an area where we can anchor an ablation line to. It's helpful to ablate around at least one pair, if not both pairs, of pulmonary veins, which again can serve as a good anchor for a mitral annular flutter line, but also to eliminate triggers because these patients often will have atrial fibrillation. So the two most common lines that are created for mitral annular flutter are, number one, this lateral line connecting the mitral annulus to usually the left inferior pulmonary vein location. That has a couple problems associated with it. Number one is the coronary sinus tends to run epicardially here and can serve as a heat sink. And so sometimes ablation lesions need to be made actually in the coronary sinus to ablate essentially the epicardial surface of the left atrium there to complete the line and get transmural block. And also the ridge that sits between the left pulmonary veins and the left atrial appendage can be very thick in some patients, and sometimes you have to ablate on both sides of that ridge, or sometimes people will actually ablate in some fashion up in the vein of Marshall, usually injecting alcohol, or if it's big enough, actually even putting the ablation catheter up in there in order to kill off the tissue of that thick ridge to complete the posterior end of the line near the pulmonary veins. And number two, the other line that sometimes people create is referred sometimes to as an anterior or a septal mitral line, and it involves connecting the top part of the mitral annulus, usually to the right superior pulmonary vein, or in fact the circle that was created, ablation around the right veins. That tends to be a little bit easier in terms of creating transmural lesions, but it tends to be a really long line, and that can sometimes take a little bit longer or be problematic to make sure that you in fact create a complete line of block. And also the artery that runs to the sinus node can sometimes run in this area, so one of the risks here is potentially injuring the sinoatrial node artery and having sinus bradycardia thereafter. And as you get close to the right pulmonary veins posteriorly, you have to remember, of course, that the phrenic nerve can run in that area as well, so you need to be careful not to injure that structure. And lastly, of the most common flutter circuits, a roof-dependent flutter is a revolution of the wavefront around the pair of pulmonary veins that was ablated, traveling between the left and right pairs of veins and up and over the roof in one direction or the other, anteriorly or posteriorly. And in this case, if you connect those two circular ablation lesion sets with a roof line, you'll terminate this type of flutter. Here, in fact, is an example of that type of roof-dependent flutter, and you can see it in this advanced 3D activation map. You can see this wavefront traveling across the roof, down the posterior wall, around the veins, and then back up, and then back to the roof again. And you can see the range of colors that travels around that circuit. Here we can see the voltage map showing that the veins had been actually isolated at this point, and we can just create a roof line between the left pulmonary vein lesion set and the right pulmonary vein lesion set, and that will interrupt this flutter. You could also actually make a floor line in this case and create a slightly, in this case, longer line between this anchor point and this anchor point, and that would serve just as well, or to be honest, anywhere in the middle. But you have to remember here that the esophagus sits right behind the left atrium, and you want to, again, create a line that is the safest and most effective. And considering inadvertent heating of the esophagus as a risk, is important to consider as you design a lesion set to treat this flutter. And thank you to Dr. Laslett for submitting and allowing me to use this terrific activation map. The purpose of this video is really not to provide a comprehensive technical guide on how to perform ablation, but I did want to touch on a couple points anatomically with the most common type of flutter, right atrial flutter. And again, the goal here is to create a line of block between the tricuspid annulus and the inferior vena cava. But you have to remember, as is really nicely shown in this image by Dr. Asirvatham, that this is not a flat surface. If it were, this would be really easy. But in fact, there are pouches and ridges, and that can be problematic in terms of positioning the ablation catheter, getting good contact, and making sure that you're not stuck in a little blind end that can overheat. So sometimes having an irrigated catheter can be very useful when you're dealing with an irregular surface where you might be stuck in a little nook or cranny along the way. And certainly the eustachian ridge, which can be very prominent, sticking up into the right atrial chamber between the inferior vena cava and that isthmus, can be problematic, but not so much if you realize that it's there. And often using intracardiac echo can be very helpful to make sure that you ablate all parts of this ridge as well as the floor between the ridge and the tricuspid annulus. Here is an intracardiac echo image showing how the floor of the cavotricuspid isthmus is often not flat and simple. Here is the right atrium on this intracardiac echo image. Here's the right ventricle. Here's the tricuspid valve between the two. And here is the cavotricuspid isthmus. Notice it's hardly flat, and you have this big finger-like projection. That's that eustachian ridge between the inferior vena cava, which is going to sit over here, and the rest of the isthmus itself. So this structure can be in the way both physically and electrically. You can have signals travel through this ridge, and if you don't ablate it, but you ablate everything else, you won't get block. So typically you have to position the ablation catheter in this candy cane-like shape coming up from the inferior vena cava, curving over the isthmus and down into that far side of the eustachian ridge, kind of tucking it right in here to ablate the base of that. But also you sometimes need to work your way up and actually ablate the length of this ridge as well, or the height of it, I should say, on both sides. Here's a really nice image, and I get from another one of my Twitter buddies, and I again really appreciate everyone allowing me to share their great videos. But this shows an ablation catheter in exactly that candy cane-like configuration, curved over the eustachian ridge and ablating the base of it on the valve side of that ridge, often very necessary in order to get a line of block. This pair of images is from an early case where I did a flutter ablation that was very problematic. It was difficult for many reasons, one of which was simply just positioning the multipolar catheters to sit right in the right atrium and to sit in the coronary sinus. The ostium of the coronary sinus was difficult to get into, and there was a tight valve just beyond it, so I could barely get that decapolar catheter in. But the biggest problem was getting block on the isthmus. And in fact, I discovered a prominent electrogram at the location where this 8mm catheter is sitting. It looked like it was floating up in the right atrial chamber in both the RAO and the LAO views. And yet there was a big prominent electrogram. And it was only when I finally put up an intracardiac echo catheter that I recognized that the ablation catheter was sitting up against a very big prominent eustachian ridge, and that needed to be ablated in order to complete the line of block. It probably looked something like this, where you had this big finger-like projection ridge on the inferior vena cava side of things, and it really required ablation, as I described before, both on the valve side of the ridge, but also on the inferior vena cava side of the ridge, because it was thick enough that we needed to get transmural ablation through it in order to create a line of block. Here's an echo image, an intracardiac echo image of exactly this type of ridge, and here's the ablation catheter sitting on the IVC side of the ridge, which was necessary to get block in this case. I wanted to think for a moment about how you decide which direction to make your ablation line, especially when you have a long line like this anterior mitral flutter line that we spoke about a few slides ago. Here is a scarred left atrial chamber in somebody who had atrial fibrillation and mitral flutter. And the mitral flutter in this case was counterclockwise around the mitral annulus. This patient had already now a set of ablation lesions around the right and the left veins to perform pulmonary vein isolation. And in order to ablate this flutter, we chose to do an anterior or a septal mitral flutter line. And it's a very long line, but it actually can work really nicely to create a line of block. Different people have different preferences, and there are certainly pros and cons, as I discussed before, of where you make your mitral flutter line. But this is what we chose to do in this patient. And the question is, does it matter if you start this line on the valve end or on the vein end? And it doesn't in terms of the eventual line, but if you want to know that you're doing the right thing and you're making good progress in terms of creating a line of block, it helps to do it in one particular direction. If you start this flutter line at the vein end of things, and let's say you're halfway through, what happens to the cycle length of the flutter? The answer is nothing, because the route that it follows, it's going to hug as the shortest distance, it's going to hug that mitral annulus. So you're going to have exactly the same route and the same amount of time it takes to get around that route, which you haven't altered as you approach the valve. And in fact, it's not going to be until you get very close to the valve that you're going to start to get edema, and then eventually ablation and block and termination of the flutter and a demonstration of block across your line. But what if you start at the other end, at the annular end? And let's say you're halfway through at this point. Well, what's going to happen to the cycle length of the flutter now? Will you know even before you've created a line of block that you're doing the right thing? Yes, you will, because now you've actually interrupted the shortest route, and in order to travel around the line of block that you are progressively creating, the route is longer, traveling around the line that you've created, assuming that you got block at the valve end of things. And you'll see a slowing of the cycle length. I kind of like to see this as I'm progressing as an indicator that in fact I'm doing the right thing. This is basically what you'll see as you start to ablate across that line in the specific direction I mentioned. Here we're going to start at a cycle length of 210 milliseconds, and we're in the middle of this line. Ablation results in a little bit of a cycle length slowing, and then a little bit more slowing, and then a little bit more slowing. And for me, this is very satisfying to know that in fact I'm doing the right thing as I continue to ablate. And then eventually, of course, you'll get the flutter to terminate. And then when you're in sinus rhythm or during pacing, you'll make sure that you have durable block across that line to prevent the flutter from recurring. Let's review what happens to the electrograms in the ablation catheter during a flutter ablation. Let's quickly review how electrograms are recorded in a typical ablation catheter, which has 4 recording electrodes grouped in 2 pairs, a distal pair and a proximal pair, and of course ablation is performed from the larger electrode at the tip of the catheter. For those who have seen my introduction to electrograms video, you may recall that when you have a bipole that is taking a recording inside the heart, there will be a field of view in the immediate vicinity of those electrodes that will record a sharp electrogram, or also known as a near-field recording. That's the immediate area around those electrodes, but because the unipolar recordings from those electrodes actually see a little bit further away, you can also record a little further afield from each bipole, and that's known as the full recording range of each bipole. And the electrograms that are a little further away will be more blunt in nature, more rounded in nature, and often of lower amplitude. So please keep in mind these concepts of near field and far field electrogram recording as we look what happens to the electrogram in the ablation catheter during radiofrequency lesion formation. Here we've started an ablation lesion, and you'll see encircled in red the ablation distal bipolar recording channel. And notice that as the ablation lesion begins, you see very sharp electrograms demonstrated here in the ablation distal pair of electrodes. But as the RF lesion progresses, you start to see a blunting of the electrogram here toward the end. Well, why is that happening as we're making an effective lesion and damaging myocardium? If you think of the myocardium here in pink as a mass of cells, and there is the near field recording from that distal pair of electrodes, the sharp electrogram recording range. As we make an ablation lesion from the distal tip, you're going to be killing off that myocardium that's within that sharp electrogram near field range, and you're going to be left with the far field element of the recording, and thus the sharp component of the electrogram is disappearing, but the blunt component remains. That tells you that you're making an effective lesion. Here's another and sequential change that you may see as you're creating a line of block across the isthmus or wherever you're creating a line to disrupt atrial flutter. Look here, encircled in red is an electrogram which already has adopted somewhat of a far field appearance, but as we progress here through this ablation lesion, you start to see two components of the electrogram appear, forming sort of a W shape in this case. We refer to this as a double potential, and the question comes up, why are we seeing this? If we again go back to the concepts taught in the Introduction to Electrograms module, you'll recall that if there is a line of block and a wavefront approaches it, in order for it to get to the other side, it has to travel around the line of block, an indirect route. If you have a bipole that is positioned right on that line of block, such that its near field of view includes tissue on both sides of the line, then as the wavefront approaches, travels around to the other side, you're going to get a split or double potential, because that bipolar recording is going to see signals on first one side of the line and then the other, separated by the amount of time that it took to travel around the electrical barrier. If we ablate across the cavotricuspid isthmus, then we're creating essentially a line of block. Here's the ablation catheter moving and creating one lesion next to the other, and if you have a wavefront that approaches that line, it will have to travel around that line to the other side, and you're going to have that, by definition, bipole right on the line of block, because that's the same electrode that you're ablating from. And so here is that bipolar recording that is being created and widening as we're creating this line of block. Let's examine the electrograms in the ablation distal pair of electrodes during this flutter line as we terminate atrial flutter. Here we have counterclockwise atrial flutter traveling around the right atrium, and accordingly we see in this halo catheter the sequence of electrograms as you'd expect from that counterclockwise circuit. Let's turn our attention to the ablation catheter distal pair of electrodes, where we see this double potential happening during atrial flutter. And what's going on there, of course, is we've created a line of block, not complete line of block from one barrier to the other, from the IVC to the tricuspid valve, but enough that you're having a split potential as you record along that line. The signal still gets through, but there's a delay so that the electrogram on one side of the line is separated temporally from the electrogram on the other side of the line, and it shows up here as this split potential. As we make that last final lesion and finally achieve block, you're going to see, first of all, the flutter terminate. And second of all, you're going to see in that split potential only the first of the two signals, because that's the wavefront approaching the side of the line before it would have crossed that line and that barrier. But once the barrier is completed, then you're not going to get through. That's the point of termination of the rhythm, so the second electrogram on the far side will no longer be seen. Let's review another little detail about lines of block and gaps in the line. Here is that same cartoon showing a double potential as you sit on this line of block. But what if there is a gap, an opening that forms closer to where our recording bipole is located? Well, now the wavefront that approaches the line can skirt through that gap a little bit closer to the bipole, and there will be actually a shorter period of time between the first and the second electrogram. Watch here in the bottom right as I show what happens to the electrograms, that split potential, if a gap were to open up close to our recording bipole. And what if we actually move the bipole right on top of that new gap, such as this? Now we're going to be recording right at the point of breakthrough, so you're going to in fact have a continuous electrogram and a very narrow double potential, if any. It may even be a single potential, because really you're just seeing the wavefront pass through that gap. It will depend on whether there's delay in that gap, which could in fact create a double potential, but if it gets through relatively quickly, you may see only a single potential, demonstrated in the bottom right here as a complex signal occupying very little time. We can capitalize on that principle of a gap in an electrical barrier and the distance between the two components of a split potential to allow us to map a line that is incomplete. So let's say you have a wavefront that approaches the line that you had created and the signals are still getting through, and either the flutter is continuing or you're pacing and you're seeing signals get through your line. How can we find the gap in order to ablate and complete the line of block? Well, we can place our ablation catheter right on the line so that we're recording signals on both sides, and we can look at the spacing between the two parts of a double potential as we drag our catheter back across the line. Notice how as we approach the gap, the signals get closer together, and as we move away from the gap, the signals get further apart. So using that principle, we can then position the ablation catheter right at the narrowest double potential or even single potential and know that that is likely a site of breakthrough. We can then apply radiofrequency energy at that location, and we can complete our line of block, and you'll see sudden separation of the signals on both sides. The second signal will reverse its polarity and increase the time it takes for that recording to occur, because now we're not getting through the line, but we're approaching the other side of the line, in this case, all the way around over the roof of the right atrium to hit the line from the opposite direction, thereby giving it a greater time between the two signals and a reverse polarity in the signal on the opposite side of the line from the oncoming wavefront. For those who use 3D mapping techniques during a flutter ablation, you can leverage that 3D map not only to show the flutter before ablation begins, but also to map a location of breakthrough if a line of block is incomplete. And let me again extend my great thanks to my Twitter colleagues for sharing such wonderful images and movies and allowing me to use them in this educational video. Here you can see on the right-hand side a line of block. This is the voltage map showing low voltage here where ablation was performed. And here on the left, you can see the sequence when atrial flutter was present coming here through the isthmus. And now that a line of block was created but is incomplete, this area can be remapped. And let's see what happens when we play the movie to demonstrate the wavefront approaching the line and breaking through. You can now in 3D space see the earliest time that signals are appearing on the opposite side of the line as a confirmatory or alternate method to using double potentials to find that site of block and place a lesion to complete the line and ensure that flutter does not recur. And here we are placing that final lesion in such a case where atrial flutter terminates. I want to highlight, though, the first sinus beat after flutter has terminated in our duodeca catheter, and notice that we achieved block in order to terminate the flutter, but I don't see any evidence of discontinuity in the wavefront here during sinus rhythm. In the next module, we're going to review why we don't use sinus rhythm to assess for block once the flutter terminates. So let's review why it's important to pace from one side of the line when we're looking for block rather than relying on sinus rhythm. So here again is our isthmus, and here we've created a sequence of radiofrequency ablation lesions across the isthmus, and we've terminated atrial flutter. And so the wavefront approaches our line and it blocks. And the question comes, why is that not sufficient? Can we not stop the procedure at that point when flutter terminates? And the answer is that when we make RF lesions, you're creating a zone of permanent injury of myocardium immediately adjacent to the catheter tip, and there's a surrounding zone of edema that is temporary, and those cells, if they are not then subsequently injured permanently with another lesion, that edema can go away, and if you don't have close enough spacing of your lesions and therefore you don't have overlap of your zones of permanent injury, you can get gaps in the line so that a wavefront can now approach your line a period of time later and you can get through, maybe with some delay, but nonetheless your line of block is no longer intact. It's important to have a waiting period, therefore, after creating a line of block. Some people wait up to 30 minutes, or giving adenosine to try to wake up myocytes that have been temporarily injured but are prone to recover. And at that point, you find that there's more work to do. So here we are, as I was alluding to from earlier, looking at sinus rhythm. And what is the difference on the left and the right? It turns out that the electrograms recorded on the left were prior to an ablation line, and on the right are after an ablation line was created across the cavo-tricuspid isthmus. But the activation sequence is exactly the same. And so the question is, did we recover conduction across our line, or do we have block? And let me demonstrate why sinus rhythm is not optimal for assessing block across the cavo-tricuspid isthmus. So here's my simple diagram of the right and the left atrium again. And on the floor in green again is my cavo-tricuspid isthmus. And now here we've created a line of lesions across the isthmus, and we're going to see if there's block. Here's why sinus rhythm is not optimal to see if conduction is occurring across that line or if it's blocked. The sinus node will fire, and it will send competing wavefronts around both sides of the right atrial chamber, down the lateral wall in front of the crista terminalis and over on the septum. And both of those routes are of similar length because the sinus node is 180 degrees on the opposite side of the chamber from our line of block. So you're able to depolarize and reach both sides of the line at a similar time frame, and you don't really need to rely on crossing the line in order to activate tissue on the other side because both sides are being activated through different but parallel routes. And now here we've placed the duodeca catheter around the right atrium, and let's again look at sinus rhythm and see what happens to the electrograms in our recording bipoles during sinus with a line of block across the floor. There's the sinus node firing, sending competing wavefronts around both sides of the atrium, and let's look at the activation sequence in our duodeca catheter. You can see here we have one wavefront traveling from D10 all the way to D3, and that basically reflects this wavefront coming down the lateral aspect of the right atrium down toward the isthmus. And as this wavefront, we don't have any electrodes on the septum, but as this wavefront comes down the septum and approaches the isthmus from the opposite direction, you're going to get a wavefront going from D1 through D3. So D3 on the opposite side of the chamber, sitting right on our line of block, is going to be the latest site of activation and therefore the latest electrogram during sinus rhythm. And you won't really need to cross that line of block in order to activate D4 or D2 earlier, because they're being activated through different routes and not through the line. On the other hand, if we look at pacing from the coronary sinus before and after ablation, you will see a difference in the activation sequence in our catheter. Here on the left, before ablation, you're going to see the wavefronts meeting over around D6, and after ablation, you're going to see discontinuity in the electrical wavefront between D3 and D4. And let's again look at our diagram and figure out why this change occurs as we create a line of block. Here are our atria. Here's pacing from the coronary sinus, and the difference now, pacing close to the line on one side, is that the timing of getting to the other side of the line is going to be critically dependent on whether we actually conducted through that line to get to that tissue on the far side, or if we took this much longer route to get over the top of the chamber to finally reach the other side. Here's that duodeca catheter in place, and let's start by looking at what happens during coronary sinus pacing when we don't have block, but we have intact conduction through the isthmus. There's pacing, and here are the wavefronts traveling around the atrium to the opposite side in both directions, including across the isthmus. You can see in aqua, you're going to have the wavefront traveling from D1 through D2 and all the way over here to D6. That's reflected here in our electrogram activation sequence. And of course, we don't have electrograms here on the septum in this example with this catheter, but you're traveling up the septum here shown in white, and then in yellow is where we start recording from this catheter from D10 also down to D6, where these two wavefronts meet and collide on the opposite side of the chamber, and that's reflected here in the sequence D10 through D6. This is the example where we have intact conduction through the line, whether or not we've made radiofrequency ablations yet or not. Now that we've created a line of block across the isthmus and we pace from the coronary sinus again, here is the difference in the activation sequence on the far side of the line. In aqua, we're still showing that we're going to be going from D1 through D3. That will be unaltered as we create a line of block beyond D3, so that'll be the same as before. And similarly in yellow, the component that was traveling over the roof to activate these electrograms will remain the same, so this part of the electrogram sequence is unchanged. But the difference is locally on the other side of the line, here in D4 and D5, the wavefront propagation direction is going to be now this way, lateral to medial, instead of prior going medial to lateral, and the timing here is going to be much later. So now these electrograms will be in line with the ones that were created with the wavefront coming over the roof, rather than prior to a block having those electrograms be continuous with the aqua portion of the line going out toward D6. Let's break down a little further the electrograms in the duodeca catheter wrapping around the right atrium when we're achieving isthmus block and if conduction should recur across the isthmus. Let's get used to looking at electrograms on a full page printout here, where we don't have the benefit of colors and we're looking at all of the channels at once and 3 beats here on the same page. It's sometimes a little tricky to sort out what electrograms belong to which chamber, especially when we have electrodes that are sitting right at the AV groove that can show both atrial and ventricular activity. So for example, here, these electrodes that are sitting right near the isthmus, duodeca 7-8 through 11-12, we're going to see 2 electrograms, and you might first think, oh, maybe that's a double potential, until you realize that these electrograms here are actually lining up with the QRS, and those represent far field recordings from the base of the right ventricle. Notice that they're small in amplitude, they're rounded in shape, signifying them as far field, as opposed to these near field electrograms that are much sharper and correlate with the P wave that's relatively flat, but that's what's shown here on the surface EKG. So let me color code those as atrial electrograms and ventricular electrograms, which is going to be critical in figuring out the activation sequence and what's going on with regard to the presence or absence of block across the isthmus. Let's now show pacing from duodeca 1-2, and we know pacing is occurring from there because we see the largest pacing artifact in this channel. You can see pacing artifact in nearby electrodes as well, but there's this large square wave that is so large it's actually clipped in this case. That tells you this is the channel that's being paced. And that'll correspond on the fluoroscopy in the upper right to the 1-2 pair of electrodes. As wavefronts sweep in both directions here across the right atrium from that coronary sinus pacing site, we're going to see the sequence of activation reflected in our duodeca catheter. You can see in blue, you're going to have the wavefront traveling across the floor of the right atrium here from 1-2 all the way to approximately 13-14 or so, and that's shown here in blue in these electrogram channels. And then you're going to have another competing wavefront, as we've shown before, traveling up the septum, over the roof, and downward from 1920 to 1516, and that's reflected here in orange on our electrogram sequence. In this example here, we've now achieved block pacing from the same location. Here are ablation lesions shown across the isthmus, situated between 5-6 and 9-10, right around where duodeca 7-8 is positioned. And let me clarify again what is atrial and what is ventricular using the surface EKG to clarify. So these are not signals to look at when we're figuring out the activation sequence in the atrium because they correspond to the QRS. They're far-field ventricular signals, but shown in green here are indeed the atrial signals of relevance. So let's pace from CS 1-2 or duodeca 1-2 sitting in the coronary sinus. And now that we have block, let's look at the activation sequence in our same catheter. Here's pacing. There in blue is unchanged from before when we didn't have block. That's just the wavefront approaching the line from 1-2 through 5-6. That's going to be the same as it was before. But now in orange, we're going to have the entirety of the lateral wall and the lateral isthmus activated in this sequence, going from 1920 all the way to 910. And that's reflected over here in the electrograms 1920 through 910, and even in 7-8, which is sitting right next to the line. We can still see an electrogram there being the very latest location to be activated. Let's look at this example here where we're ablating. And on the first 2 beats, we have one sequence of activation, and the third, it changes. So here, pacing from the coronary sinus, we're seeing the wavefront travel up across the isthmus in the first 2 beats where we do not have block. Then look over at the fluoroscopy. We create more lesions here, create a line of block, and now on the third paced beat, we block at that electrode pair 4, and we come over the roof and down the lateral wall and lateral to medial in the electrodes just on the other side of the isthmus where we created a line of block, and now we have a discontinuous sequence of activation in our duodeca catheter reflecting that block and the reversal of direction on the other side. Another really important observation on this slide is not what's happening in the duodeca catheter, but what's happening in the ablation catheter, which is sitting flat against the isthmus as we created this line of block. Look at the double potential that we're seeing, a bit of a far field signal on one side, because maybe the catheter is sitting a little bit skewed, a little bit on one side of the line. But the second signal, which is pretty sharp, is close by. Here we have a relatively narrow space double potential on the first couple beats. But now let's look at that third beat where that second signal jumps way out. Let's just show here what the timing is. That second signal really times with D5 more or less on the lateral side of the line, and you can see as we get block, it jumps out as well. That's basically signifying that we have created block. We're now not just sneaking through a gap in the line, but we're in fact traveling over the roof and around, coming at the line from the other direction. And the recordings that are made from the tissue that's just on the lateral side of the line, that's D5, and the second component of the signal in the ablation catheter electrodes is going to be the very latest electrogram to be activated when you're pacing from the other side of the line. Here's another example just to show you with electrodes positioned maybe a little bit differently and the catheter maybe sitting a little bit differently. Here on the first two beats as we pace from the coronary sinus, we have wavefronts traveling in both directions around the atrium, meeting on the opposite side, in this case electrode pair number 6 on the first two beats. And on that third beat, we've now created some additional lesion there and created a line of block. So again, on the medial side of the line shown in blue, that's going to be unchanged because that's the same side as the pacing is occurring. But on the far side of the line, we're going to get reversal of direction and a jump out of that of the electrodes on that side, D4 and D5. Being now continuous with the wavefront coming over the roof and down the lateral wall, and that shows us that we have block. Here we can see as we continue pacing over time that we have persistent block from medial to lateral. Again, pacing in the coronary sinus, the wavefront coming over the roof, D10 all the way through D4, showing persistent block. And if we waited 30 minutes and we continued to see this pattern, we would be satisfied that we've achieved a continuous line of block that seems durable. So it's possible to actually get conduction block in one direction but not the other. It's rare, but it's possible. And so it's conventional and advisable to make sure that when you create a line of lesions that you have bidirectional block in both directions. So the previous slide showed pacing on one side of the line from electrode pair 1, looking at what's happening on the opposite side of the line, and that showed medial to lateral block. But now let's see if we have block in the opposite direction. Here we're pacing from electrode pair 5, and we're going to look at the wavefront, the sequence of activation in the duodeca catheter. Of course, if you're on the same side of the line of block, the electrode wavefront propagation is not going to change, so we're going to travel in the upward direction. That's never going to change regardless of whether we've created lesions on the isthmus or not. And so these electrodes here are not really that relevant when we're looking for lateral to medial block. We would expect, if we had conduction across the isthmus, that we would have an activation sequence traveling from the pacing site here, now D5, through D4, 3, 2, and 1 in this direction. But notice that's not what we're seeing here. Instead, we block in that line of lesions that we created on the isthmus, right near electrode pair 4. And we're going over the roof now in the opposite direction because we're pacing on the other side of the line. And we're going to be coming down the septum and traveling in the medial to lateral direction in these electrodes on the medial side of the isthmus. And that's reflected over here in the electrogram sequence. D1 precedes D2, which precedes D3. That shows us that the wavefront is moving in the opposite direction than what we would have expected. Pacing from D5, if we were conducting through, we would have expected the sequence to travel in this direction. So we've now confirmed, just pacing from one site, that we also have lateral to medial block. And the reason that we know this is because we have electrodes sitting right here on the isthmus, and we can assess the direction of wavefront propagation on the opposite side of the line. With two catheters sitting in the heart during a flutter ablation, one halo around the right atrium and the second in the coronary sinus, we don't have electrodes sitting on the isthmus on either side. And so you're going to need to do other maneuvers or process the information in a different way to see if you have block across the isthmus. For example, here, if we're looking for lateral to medial block, and we have a wavefront that travels over the roof and down the septum and traveling in the medial to lateral direction on this side of the line, we're not going to know that because we don't have any electrodes located here on the floor. And we're going to review a little bit later other techniques when you don't have electrodes from a multipolar catheter sitting on the isthmus, how you can confirm block across the line. Here we're going to show recovery of conduction, again looking at a duodeca catheter wrapped around the right atrium and into the coronary sinus. Here we're pacing from duodeca 1, 2, and we see that we have block like we've shown several times already, and the orange wavefront is coming over the roof and down the lateral wall. But with time, maybe this is 15 minutes after the line of block was created, suddenly as we continue coronary sinus pacing, we see there was a sudden change in the activation sequence, showing us that we've regained conduction. There's been some loss of edema and recovery of conduction across the line. So here we're pacing from 1, 2, and we're going to travel through the line to 7, 8, 9, 10, 11, 12 in that direction, just as we're seeing here in this blue arrow in the electrogram sequence. Now the collision point, the latest point of activation, is over here at 13, 14. Here's the latest electrogram here, in contrast to when we did have block, where the latest electrogram was in 7, 8, which was just on the other side of the line. Let's talk a little further about typical flutter and getting isthmus block and using a multipolar catheter to assess wavefront propagation, but let's get into a few more little details about the subtleties of verifying block and a couple pitfalls that could cause you to come to the wrong conclusion. First, I want to review some slides that I've shown before to compare and contrast something that you may or may not have seen. Look at the activation wavefront here in the left and the right panels while we're pacing from the coronary sinus and having conduction come through the isthmus. The activation sequence looks different in this identical 20-polar catheter. On the left-hand side, the wavefront is colliding all the way here at D9, and on the right-hand side, we're colliding here at D6. And so the question is, are these different in terms of whether the isthmus is blocked or not? And if not, why do they show such a different activation pattern? Well, let's look at the fluoroscopy. Here on the left, the duodeca catheter was actually pushed further into the coronary sinus. So electrode 1 is sitting much more leftward, and electrode 10 is sitting much lower. Whereas on the right, we've deflected the catheter up, and electrode pair 1 is sitting right at the ostium of the coronary sinus, maybe deflected up against the roof, not that far leftward, and electrode 10 is actually much higher up near the superior vena cava. So let's look what happens when we pace from electrode pair 1 in each scenario and where the wavefronts collide that are traveling across the floor versus across the roof of the right atrium. Here on the left, pacing from electrode pair 1, we're going to collide at D9, which will be the latest electrogram. Here we're conducting through the isthmus as shown in blue, but the distance from the pacing site to the far side of the atrium is going to be electrically equivalent over the roof and across the floor, so that 9 ends up being the furthest electrode where these wavefronts meet. In contrast, on the right, we're pacing sort of a little bit higher on the septum here rather than more leftward, and we're going to have a wavefront again come through the isthmus in blue and over the roof in yellow and then orange, and we're going to meet at electrode pair 6. Now the physical distance may be a little bit different. Maybe though there's a little bit of slowing in the isthmus even before ablation was started, but electrically speaking, it's a tie to get to electrode pair 6. So it has everything to do with the pacing site and how the catheter is positioned, where the collision is going to occur. So you need to factor that in and at least know in your mind, and initially fluoroscopically or using a 3D mapping system, where all your electrodes are so that you can properly interpret wavefront propagation. On this slide, we're going to also talk about wavefront collision location, but we're going to talk about it with regard to conduction across the isthmus rather than electrode and catheter positioning. So let's first start with scenario 1, where we're going to pace from the coronary sinus, and we're going to have a line of block that is intact and a collision of wavefronts on that line, as we get one wavefront reaching the line from one side and then blocking completely. And then you have to get to the other side of the line, you have to travel up and over the roof and down the lateral wall, and you're going to have that wavefront reach the line on the other side at the very latest time frame. And again, you're going to have the collision right here. What if, however, we have recovery of conduction after a line was created, or you haven't quite achieved block, but you do have conduction slowing, but gaps remaining in the line? If we pace from the coronary sinus again, you may have signals getting through the isthmus, but with very slow conduction, delaying that wavefront propagation through the isthmus, and you may be getting through but have a very low lateral point of collision between the wavefront that came across that slowed isthmus and over the roof with normal conduction velocity to the down the lateral wall of the right atrium to collide here. That's all fine and good, but what if you have that scenario where you have two catheters and you actually don't have any electrodes sitting here on the isthmus? So if you had a wavefront that propagated in this direction on the lateral part of the isthmus, you won't be able to see it in your multipolar catheter. If your collision of wavefronts was up here, no problem. You can see the wavefront propagating upward. But if your wavefront collision point is anywhere beyond the end of this catheter to the line, you're not going to see it because you're not recording electrograms from that location. So how are you going to know if you're sneaking through with very slow conduction and you have wavefront propagation in the medial to lateral direction on the lateral side of the line if you don't have electrodes there in a multipolar catheter? Let's look for a moment at two scenarios where the catheter is in the same place and we're progressing with our ablation line. Here we're pacing from the coronary sinus. This is before we started ablation, and we have wavefront propagation over, colliding high up on the lateral right atrium at electrode pair 9. As we start to make lesions, even if we don't have block, we will start to get slowed conduction as we get to close to completing the line. And so here we're pacing again from there. Notice how we've not moved the catheter, but the wavefront propagation and location of collision will change even before we have block. It'll migrate downward. So that's one way to know that you're achieving some progress with ablation along the line while you're CS pacing, because you're going to see the collision point start to migrate downward closer to your line, assuming you have electrodes at those locations. And it might look something like this if you have a multipolar catheter looped around with electrodes in that location. Notice that we have, first of all, a double potential in electrode pair 4. That's right where we're making our ablation lesions. So we've reviewed that already. You have a double potential because of delayed conduction through a gap in the line. But notice that even though there's a gap in timing, the activation sequence goes from D5 out to D7, which is later than D5. And those are both on the same side of the line. That suggests you have a wavefront traveling from 5 towards 7, telling you that you have gotten through the line and you are propagating in that direction. You don't have block. Now let's get into a challenging scenario where we don't have electrodes in a place lateral to the line, and see how hard it can be to detect whether or not we have isthmus block. So let's pace here from electrode pair 7-8 in the coronary sinus. And you can see in blue wavefronts propagating in both directions. That's not going to tell you anything about the line of block. But let's look at the halo, where in purple we have an activation sequence that's traveling from 10 all the way around to 1. And we're used to seeing this sequence of activation present when we have achieved block. But have we? It's possible that we could be conducting on the lateral side of the line in this direction or in this direction, but since we don't have electrodes, we just don't know. What if there is a collision of wavefronts over here beyond electrode pair 1, and we just don't have the recording capabilities with this setup to see it? Too bad we don't have any electrodes in this location. But actually we do. If you think of the ablation catheter and use it like we've discussed once before, but now we're entirely relying on those electrodes and the ablation, the electrograms in the ablation catheter, let's look at that double potential in the ablation distal pair. Notice that the second of the two electrograms is occurring earlier than halo 1. Let's talk about that double potential. We're traveling in the medial to lateral direction across the isthmus, and that second electrogram on the lateral side of the line is earlier than halo 1. That tells us, since we've gotten to this location early, and this isn't the very latest spot, it must mean we've come through the line in this direction, and it's traveling up toward electrode 1. Had this been blocked, this electrogram on the far side of the line would have been later than halo 1 and the very latest part of the right atrium to be activated, but it's not the case. So the ablation catheter is the only way that we know we don't have block yet, even though it appears that way from the halo catheter. At first glance, it may appear that this slide looks identical to the previous one, but there's one really important change that we're going to highlight. So here we've continued to ablate across the isthmus to try to achieve block. And as we pace in an ongoing fashion from coronary sinus 7-8, all 3 beats on the page here show an activation wavefront from 10 to 1. But again, it's really important to look at the signals in the ablation catheter itself. On the first 2 beats, you have that narrow double potential that we talked about on the previous slide, because we're conducting through the isthmus, we haven't yet achieved block, and that second potential on the far side of the line is earlier than halo 1, signifying that our collision wavefront is somewhere here lateral to the line, because we've gotten to this part of the tissue earlier than halo 1, meaning the signal must have come through, the wavefront must have come through the isthmus, albeit with slowed conduction. But on that 3rd beat, the signal jumps out. Finally, we have a second potential, a split potential that's really wide, and that second potential is now later than halo 1, meaning that this part of the atrium is finally the last part of the right atrium to be activated, because now we've achieved block and the wavefront is coming down from 1 through this location without electrograms right to this part of the line, which we can detect in the ablation catheter, and we finally have block. So thinking about that electrogram timing, where it is the second signal is initially in front of halo 1, and on the 3rd beat after halo 1, will show us that the wavefront is traveling on the first 2 beats across the isthmus in a slowed fashion, but on that 3rd beat, the wavefront travels toward the line on the one side, blocks, and finally we have to go over the roof in order to get to that lateral part of the isthmus, just lateral to the line, as indicated by that late potential. One other pitfall to watch out for on this slide is not being fooled by this electrogram, which is a far-field ventricular electrogram that lines up with the surface QRS. You should recognize that there are in fact 3 electrograms here. 1 and 2 are atrial, closely spaced, and the 3rd is ventricular. And it is still present on that 3rd beat, but it's a little bit swallowed up or superimposed upon the true atrial signal that has finally jumped out. That's why I highlighted in previous slides, always assessing using the surface EKG at different points in time what is an atrial and what is a ventricular signal, so that when there is a change, you know how to interpret it properly. Here's an even trickier example with electrodes on the isthmus, where slowed conduction can be misleading, and you might miss the fact that you have recurrent conduction across the isthmus if you're not paying close attention. The two beats seen here initially look similar in terms of the activation sequence lateral to the line. From 10 through 5 is what it looks like. But the eagle eye will notice that as we pace from D1 and we look at the activation wavefront traveling over the roof and down the lateral wall, we'll see that in electrode D5 there's a difference in the shape. And if you're really careful, you'll see a difference in the timing. Here, electrogram D5 is somewhat tied, maybe even starting slightly sooner than D6, whereas in the second beat, it's clearly later. But more important, or as important as the timing, is the fact that the polarity has flipped. All the other electrograms are the same in the two beats, but the one in D5 has changed and inverted. And the reason for that is on the first beat, we actually are conducting through the isthmus, as shown in purple here, very slowly. And so we've approached that D5 bipole in this direction, creating an electrogram of one particular shape. But between the first and second beats here during RF, we finally have achieved or re-achieved block, and now the wavefront is approaching this D5 electrode in the opposite direction, changing the polarity in that electrogram, signifying both by the electrogram morphology and by the timing that we have re-achieved block. If you hadn't looked carefully and noticed this timing and that the polarity had changed, in this case we originally had this polarity when we had block, but we had recovery 15 or 20 minutes into our waiting period. If you hadn't noticed that polarity change, you wouldn't have known to place further RF lesions along the line to re-achieve block. The collision wavefront here is very low, and we wouldn't have seen this at all if we didn't have electrodes on the isthmus, and we would have had to rely on the ablation catheter to interrogate the line. One other subtlety here is if you look at the far field signal in electrode D4, which is right where the lesions were created, you're going to see an earlier appearance of that far field signal along ablated tissue in D4 here, and it jumps out even later than D5, again showing in the second beat that truly we have block and the wavefront is traveling from D5 even to D4, where you see a little bit of electrogram just lateral to the line here in that far field electrogram. And lastly, on this module, I want to show you a little trick using the surface EKG. If I asked you, while we're pacing here in the coronary sinus, where we achieved isthmus block, would you be able to tell? Notice that in surface EKG leads 2 and 3 in AVF, the P waves are mostly negative, signifying a superior wavefront propagation from the floor of the atrium upward, consistent with pacing from the coronary sinus. If you look carefully, though, at the end of the P wave, you'll notice there's a sudden change between beats 3 and 4, from a flat terminal portion of the P wave to a raised positive component of the P wave there. And let's see if, in fact, that's the location where we achieve block. Sure enough, it is. And if we look at the intracardiac electrograms, we'll see a shift in activation sequence from here to here, showing that we've achieved block. So why did the P wave morphology change when we achieved block? Let's review the fluoroscopy and look at the activation wavefront on the lateral part of the right atrium on the beats 2 versus 3. So when we're actually conducting through the isthmus, as on beat 2, we have competing wavefronts that are colliding over here near D8. and you have both an upward component on the lateral part of the right atrium where the crista is located, and a downward component that may sort of cancel each other out at the latter part of the P wave. The lateral part of the right atrium is, of course, the end of the P wave as we pace from the coronary sinus. However, once we achieve block, instead of having competing wavefronts canceling each other out, we have only a downward wavefront traveling down the crista, down the bulk of the lateral right atrium, all the way to our line of block. And because the end of the P wave is conducting from a head to toe, a downward fashion, the end of the P wave is going to be positive in the inferior leads. And that's just another surrogate, another trick that you might find useful on occasion, especially if you don't have electrodes along the isthmus. You can watch the surface P wave during coronary sinus pacing to see when you've achieved block, and you'd see the reverse happen if you had recurrent conduction across the line. You might lose that positivity at the end of the P wave because you've again started to conduct upward in the lateral low part of the right atrium. Let's bring it all together, looking at the electrograms in the ablation catheter in scenarios where you're not looking at any other electrodes in the right atrium. This can be either because your right atrial multipolar catheter is high up away from the isthmus and you really need to rely on the ablation catheter electrograms to assess block, or you may have a lean and mean ablation approach where you don't even have a multipolar catheter in the right atrium. So here's an example during ablation while we're pacing in the coronary sinus, and we can see in the ablation catheter there's a narrow double potential that starts to widen out as radiofrequency energy is delivered. That delay in the second electrogram demonstrates that we're achieving slowed conduction, which is progressing during RF application. It doesn't necessarily tell you yet that you have complete block. You'd need to assess two different locations lateral to the line during CS pacing, as I'll show in a few slides, but it does show that you are achieving delay at least in that isthmus. Let's look now at what the multipolar catheter shows here, and it indeed shows between beats 2 and 3 you've achieved a difference in the activation sequence in this multipolar catheter. You still don't have block, as it turns out. Notice the sequence here in D6 to D7. You're still coming across the isthmus from 5 to 6 to 7, but you in fact have achieved delay, and there's here a double potential in D5, which is likely sitting right on the line of ablation. Here's another example where we see a sudden change in timing in the electrogram seen in the distal ablation bipolar recording. We can see on the first 2 beats there's a shorter timing to that electrogram, and there's a sudden jump in that third electrogram. And in addition, there's a change in polarity. We see sort of a little positive electrogram here, and it becomes totally negative here, suggesting that we've achieved significant delay and perhaps block. And if we look at the activation sequence in a multipolar catheter that's sitting there, you can again see a sudden change in the activation sequence, showing that you're achieving success along the line of block. Again, you have to assess 2 different locations lateral to the line, but this is very important during radiofrequency energy to know that you're making good progress and maybe achieving the result you're looking for. Here's yet one more example where we see a sudden jump out in the timing of the electrogram in the ablation distal channel. From beats 2 to 3, there's a sudden change, and again there's a change in polarity where we're mostly negative here at the beginning, and then suddenly it turns to positive, suggesting perhaps a different direction of wavefront propagation just lateral to the line. And let's again look at the electrograms. Here it does indeed show that you have a sudden change in activation sequence from this beat to this beat, suggesting that maybe we've achieved very significant slowing or block. So let's discuss how you can truly assess whether you have block across your line once you've finished radiofrequency applications and you're looking to test in the absence of a multipolar catheter sitting on the isthmus or around the right atrium. Here we have only 2 catheters in place. We have an ablation catheter that's now positioned just lateral to our line, and we have a coronary sinus catheter as well. We, by the way, happen to also have an intracardiac echo catheter looking at the anatomy of the isthmus during ablation. This is roughly where the right atrium is located in this LAO view. And let's say we have a line of block and we've been successful. Let's look at what happens when we pace and look at the electrograms in the ablation catheter. So if we pace from the CS os and it approaches the line of block and in fact blocks, then of course you have to travel over the roof of the right atrium to get to the ablation catheter. So we can assess the timing from the pacing site here, where the star is located, to the electrogram in the ablation distal pair of electrodes. So that's from this pacer spike here to ablation distal, positioned just lateral to the line. And here it's 160 milliseconds. If we move the ablation catheter from just lateral to the line to further away but still in the lateral isthmus, then we can continue pacing from that CS catheter right at the septum on the medial side of the line, and now the route that you would take if in fact your line is blocked is over the roof and down to this electrode that's further lateral, and sure enough we have a shorter time from the pacing stimulus to that new location of the ablation catheter, that electrogram. Comparing those side by side, here are those two locations, and we're pacing from the same site. Notice on the right, the physical distance is further away between the pacing site and our ablation catheter recording site. And if that longer distance translates into a shorter conduction time between the pacing site and the electrogram in that catheter, it must mean that you've blocked with the direct route and you are getting to that lateral location via an indirect route over the roof and down the lateral wall. One way to think about what we're doing when we move this ablation catheter to two locations lateral to the line is we're sort of replicating what we were doing before with our multipolar catheter. Think of the distal tip of the ablation catheter as representing different pairs of electrodes in that multipolar catheter. But we're really just moving one pair of electrodes to two different locations. So here on the left, it's sort of approximating that electrode pair 1 in this multipolar halo catheter, and on the right, it's sort of approximating the location of halo 2. And what we're doing is not looking obviously on the same beat, but on sequential beats, but during pacing from the same site. So if you put this together in your mind as if this were a multipolar catheter, what you're really doing is you're comparing those two sites and looking at the direction of wavefront propagation between site 2 and site 1, which you're seeing at the same time when you have a halo catheter in place, but you're looking at them at different points in time when you have an ablation catheter that you move from one site to the other. Let's think now about lateral to medial block, and we're going to demonstrate it first using a multipolar catheter, and then we'll show how you can replicate that using just an ablation catheter and a coronary sinus decapolar catheter. Here we're going to pace first from duodeca 11-12, which is sitting here on the low lateral right atrium, and then we're going to pace closer to the line from duodeca 9-10. And let's show what happens if we indeed have block across the isthmus. When we pace from 11-12, you go up and over the roof, down the septum to get to 5-6. And the same thing will happen when you pace closer to the line from 9-10, which now has a longer electrical distance to travel, even though it's physically closer to the electrode pair 5-6 that you're measuring to. And here you see a longer conduction time on the right when we're pacing closer to 5-6. That suggests that the electrical distance is further because we have block across the isthmus. Let's compare how we would replicate this without a multipolar catheter in the right atrium, but just with an ablation catheter. Here we have a demonstration of lateral to medial block by putting the ablation catheter at 3 different locations just lateral to our line. And we're going to measure during pacing to CS 910 on the medial side of the isthmus as we're pacing from the lateral side of the isthmus. And notice here in these three different locations, we're seeing the timing extend, prolong, from location 1 to location 2 to location 3. Let's look on fluoroscopy where those three locations were. You can see on the left panel, we were more lateral, and then we were coming back toward the line on the middle panel, and then back just adjacent on the lateral side of the line on the rightmost panel. And because that site here on the right was the closest, physically speaking, to the destination electrograms that they were measuring to, but it was the longest conduction time, that must mean that we have a block in our line, and of course we're taking that indirect route over the roof and down the septum to get to the medial side of the line and that pair of electrodes. So let's come up with some basic things we've learned in this series on atrial flutter. The first point is to look at the electrogram activation sequence when you put catheters in the heart, as it can give you yet additional information that you couldn't divine from the surface EKG. Remember that tale of 3 atrial flutters that all had negative flutter waves in the inferior leads and positive in V1, where we saw 3 different circuits once we got a duodecapolar catheter inside the heart. So the activation sequence will add to what you've learned from the EKG. And if you perform 3D mapping, so now you have not just 20 or 30 sites of activation, but hundreds or over 1,000 sites where you've made a detailed map of one or both atria, you're going to yet have a richer understanding of the wavefront propagation through the chamber. And if you want to create a window of interest that it shows a very consistent color scheme on your activation map, you might consider using the P-wave to set your window of interest, the DePonte window, instead of creating a symmetrical window around your reference electrogram. If you want yet more information, then you can do entrainment. There are examples where your 3D map shows what may be a circuit, but it could be a passive circuit and not the actual active flutter circuit. So ablation of the circuit that appears to be the one of relevance may not terminate the flutter. But if you entrain, you'll know for sure whether that entrainment site is in the active flutter circuit or not, and it will add yet more information to what you've seen on your 3D electroanatomic map. When you make an ablation line, you should be sure to anchor it to electrical barriers, and if you're going to be going to a vein structure, either you should have block around the ostium of that vein, whether it's the superior vena cava or pulmonary veins, or you can ablate up to beyond where the myocardium travels, for example, in the superior vena cava, so that you don't have a wavefront that can travel up into the SVC and around your line and not achieving block. You should have firm electrical barriers each time at both ends of your line. And you should then prove electrical block even after flutter has terminated, because sometimes you can have edema that disappears, or you could have slowed conduction that terminated a tachycardia but didn't achieve permanent block. And the best way to do that is to pace just on one side of the line and record at 2 locations, one closer and one further away on the other side of the line. And lastly, you should focus on the electrograms near the line both during and after ablation, including in the ablation catheter itself, even if you have a multipolar catheter also in that same chamber, because sometimes you can have very slow conduction and be misled into thinking that you have block, but really you have slow conduction, and you'll only know that by interrogating the other side of the line when pacing on the opposite side. I really appreciate everyone's attention. Thank you so much for listening. So here's a little bonus material for those of you diehards who happen to be still listening after almost 2¼ hours worth of material. I was looking through some old slides the other day and came across what I believe is the first PowerPoint presentation that I ever made in medicine, or at least in cardiology. And this was in about 2002 when I was a fellow, and it was about atrial flutter. So I thought I would include some slides just for humor's sake and to show how far my PowerPoint skills have come. So here's one of the first slides in the presentation showing fluoroscopy from a different era for sure, but also some really rudimentary PowerPoint skills with regard to annotation. I couldn't possibly have drawn a more squiggly line here around the right atrium. And look at my numbering scheme of the electrodes, where I started numbering, I went to some dots, I then left it blank until the very end of the catheter, really striking the attention to detail way back when I started making slides. And this slide reminds me that I learned a lot in terms of what not to do in terms of overloading animations in a presentation, where I did a drop-down animation and a fly-in animation. And here are more squiggly lines, and I've subsequently learned how to draw really smooth curves and lines in PowerPoint, but clearly that was a skill I hadn't acquired yet, or else I must have had a bad tremor or terrible hand-eye coordination. And here's the requisite slide showing Isthmus blocked with my hand-drawn catheters, which again had squiggly lines and poorly spaced electrodes that extend beyond the bounds of the catheter. And this one looks like a broken finger of sorts. And it actually reminded me, as I was looking back at these slides, of an old friend from the 80s. Maybe I was subconsciously thinking of a different way to cure atrial flutter other than radiofrequency energy. And here we are showing the pathway around the isthmus, which is blocked, which is demonstrated here as a not equal sign. And I moved the catheter over further, again showing block. In any case, it really came a long way. It's all self-taught with regard to PowerPoint skills, and maybe it's an idea for another presentation in the future to talk about the last 20 years of my experience creating PowerPoint slides, focusing most recently on better images, better animations, which I really think are very important for comprehension and teaching, especially in medicine. Anyway, thanks again for listening, and thanks for humoring me as I dredge up some old slides from almost 20 years ago when I really started my PowerPoint experience.